corneal ulcer in a manner which we all been doing, and what new can be done in these cases will be a great teaching to all of us. Please have a seat, fatapat. Okay, Prashant, all yours.
Yeah, good morning, everyone. Thank you, Dr. Titial. I think in the previous session we had a talk on the similar topic, and we heard a couple of talks on how we can enhance the diagnosis of corneal ulcer. My talk is going to be a little different, and I'll be giving you some clinical scenario where the clinical diagnosis and microbiological diagnosis do not match. I do not have any financial disclosures to make related to this talk, and let me begin with this first case who presented to us with the history of 1 month duration. There was no history of trauma, no history of similar episodes in past, and the clinical picture was a kind of a disciform edema in a paracentral and central cornea. Now, based purely on the presence of edema, this patient was thought to be caused by herpes simplex virus keratitis and was started on treatment with prednisolone acetate with acyclovir and hometropine eye drop. In 1 week, this patient showed significant response. The same treatment was continued, and you can see that over 1 month period, most of the edema has reduced. The keratic precipitates are there. But then there was a worry about this area where there is a chalky white deposit on the cornea, and there was an area of epithelial defect. When we saw, we took the corneal scraping from this area, and the microscopy revealed plenty of acid-fast bacilli, and the culture growth was Mycobacterium abscessus. Now, where did we go wrong in this case? And I think if you look carefully, right from day one, it was not a uniform disciform edema. There was an area which was showing suspicious lesions. They started worsening, and at a point where we took a scraping, obviously there was an epithelial defect. And only when we paid attention to this lesion that we were able to pick up the diagnosis. Let us take another case. Again, a patient presented to us with a long history, circumscribed corneal edema, endothelial, large pigmented keratic precipitates. I am sure that many of you will think it is herpes simplex virus keratitis and will treat with corticosteroid, and so we did the same. But on day 11, we noticed that while the edema is subsiding, the patient developed a large epithelial defect. We didn't pay attention to that, continued the patient on corticosteroid with prophylactic antiviral treatment, and on day 31, the patient turned out to be a frank ring infiltrate, which on corneal scraping showed multiple acanthamoeba cysts. And if you review the literature, you will find that all cases of acanthamoeba keratitis are described as pre-treated with corticosteroid in large number of the cases. Now here again, where we did go wrong, if you have a patient of herpes simplex virus related stromal keratitis, you will not see development of epithelial defect like what we saw here if there is an adequate antiviral prophylaxis. And at that point of time, we should have reviewed the clinical picture and possibly subjected the patient for some investigation, either confocal microscopy or. So lesson 1, even in cases so-called responding, do not lose sight of good clinical examination. Everything that look unusual, we should pay attention to and give a thought, where are we going wrong? And sometimes these subtle signs are very valuable in an early diagnosis. We should not lose sight of microbiology, although we heard a lot of talks on AI, other diagnostic modalities. Let me tell you that most of these deep learning tools are built on very classical cases. But if you present this case to any machine learning tool, I am sure the diagnosis is going to be based on what kind of input have you provided to the deep learning. Confocal microscopy, while it looks very good tool, it requires experience in interpreting the images. Let me give you another series of 3 patients who again presented with a circumscribed corneal edema. And in all these 3 patients, the characteristic or some unusual history was that they presented to us with a history ranging in weeks to months, and some of the patients presented with history of several years. They were treated as herpes simplex virus keratitis, corticosteroid started, initial response, and then as the corticosteroids were tapered, they started showing worsening again. So they were not off the steroid for a long period of time, and they did not get a complete remission of the disease. And our journey into establishing the diagnosis began with this patient whom we ourselves treated for 3 months. And then when we got extremely frustrated, we said, anyway, the lesions are central, why not to do penetrating keratoplasty and get a biopsy? And we saw what we call as a microsporidia. And in all the 3 cases that I showed, corneal scraping showed microsporidia. They finally had to undergo penetrating keratoplasty. So we learned a lot from the microsporidia, and now we have published multiple papers describing clinical features of microsporidia. I think one thing that stands out very clear in establishing the diagnosis is prolonged history, and that helps you catch and suspect this organism. Let me go to my last case, a typical fungal looking corneal infection. Microscopy also showed filamentous lesions which were suspected to be fungal etiology. However, this patient worsened very rapidly. Within week to 10 days, the clinical picture, which was localized to inferior paracentral area, became a total infiltrate. And that gave us a clue that we probably are missing. And before this case was seen, we were already aware of pythium. We compared the micro or the morphology of the fungal filament and found that we are dealing with microsporidia. This was all courtesy to Savitri, who looked at some of the unidentified fungal filaments that we had in our stock, and DNA sequencing helped us to characterize this pathogen, how to diagnose it, and even how to treat medically this organism. So lesson 3, unusual features point to mystery yet to be unraveled. In both the cases that I showed, a prolonged history and lack of sporulation was picking point for us to establish diagnosis. So far what we have discussed, no response or worsening on medical therapy after an appropriate therapy are because of the missed diagnosis and infection by uncommon organism. But there are other causes: inadequate therapy, drug resistance, and presence of aggravating factor. If you use a systematic approach, you will be able to arrive at diagnosis and unravel the mystery of non-resolution. Thank you very much for your kind attention.
Thank you, Dr. Garg, for such thought-provoking cases. And now I invite Dr. Vishal Jhanji. He will be talking on advances in dry imaging. Is he there?
I think Vishal is not here.
Go to the next one. He's running
Okay, okay. Then Dr. Sonal Tuli will be talking. She will be talking on gene therapy in anterior segment diseases.
Somebody can help, you know.
In the meantime, if you have any questions, we can just ask or discuss.
Yeah, any questions from the house? One question, Prasad, if you can answer. Now we are seeing so many cases of microsporidia. If you look into a geographical, of our country, which are those areas where you see more, and why they are seen more, why they are not seen in other parts of the country?
So microsporidia, we are seeing quite a lot of cases in Odisha. We are seeing also in southern India, Raipur. I am very sure that in India, the way water bodies are, that these cases must be there. It's only the lack of awareness that is causing us under-reporting of these cases.
I think that is a point to be highlighted. We are not actually looking for those, atypical microorganisms in our corneal ulcers. I think one point which is really beautifully highlighted is, you thought you are doing a right treatment, but patient is not getting improvement. Think of something else. If we think that way, we'll diagnose most of the cases in the right time. I think one beautiful lesson we learned today from Prashant, we have to look for something which is beyond your normal thinking also. Thank you, Prashant. We have now the guest speaker from US, Dr. Sonal Turi. I think this cornea session is, we have the Cornea Society of US here with us, and their involvement is going to make the entire session very, very lively. And please come out with questions, queries, so that we can have a good discussion. Sonal, please.
Thank you, Dr. Tan. Thank you so much for the organizers for inviting me. This is, it's amazing. I always learn so much from all these people that I look at as my mentors because they teach me so much every time. So thank you all for coming, and I'm going to talk about gene therapy of anterior segment diseases. I have no financial interests. So first let's start with what is gene therapy, right? We talk about it all the time, and basically if you look at it as a whole, it's delivering some sort of genetic material into targeted cells to correct some sort of a genetic or even acquired, and you'll see examples of both diseases in the cornea. So something different from the usual bacterial antiviral things that we do. And what are some of the things you can do with genetic material? So you can take a gene that's not working, for example, some of the gelatinous dystrophies where the gene is not doing what it's supposed to. You can silence the genes that are causing a problem, like some of the RP disorders, where you have a toxic reaction to the cells and the cells die. You can compensate for some of the ill effects. For example, you could deliver anti-VEGF to cells to make their own anti-VEGF instead of delivering from the outside. And then you can precisely edit some abnormal genes, as you'll see in some of my herpes work. So the reason I got involved with this is Dr. Houseworth, Bill Houseworth is one of my mentors. He was a faculty member when I started at the University of Florida. And he was working on gene therapy for several years before it became popular. What the dog you see is called Lancelot. He's a dog that was born with a form of LCA, so of Leber's, that makes these dogs blind. And he got injected with this gene therapy in one eye, and it was great to see this video of him going through a maze, and in the eye that he had vision or he got injected, he was avoiding the maze. And on the other side, he kept hitting the walls of the maze. And it was really, really exciting to see that. And then, of course, that drug became Luxturna, which we now use commercially, at least in the States. So we started looking at gene therapy for corneal diseases. And the problem is getting the genes to where you want it to go. And so some of the ways that you can do that is by iontophoresing, or you can inject it intrastromally, like I do for fungal ulcers all the time, which, again, I learned at this meeting. And then we use AAV vectors. So one of the things I was looking at was PTK or PRK, right? So when you do refractive surgery on the surface, you can get scarring, especially when you do a lot of astigmatism correction or deep correction. And it's caused by TGF-beta, which is transforming growth factor. It helps you heal, but it also causes scarring. And connective tissue growth factor is one of the downstream regulators, which causes the actual scarring. And so we were targeting that. And what we did was we created a protein that was the opposite. It was an antisense to the gene that causes scarring. And we iontophoresed it, and basically iontophoresis means you take an electric shock and you drive it into the cells. And so here you can see in this mouse, we've delivered it, and you can see here that you can see how that the fluorescein protein has gone deep into the cornea, and then you can see the entire cornea lights up because it's driven into the cornea and actually goes into the anterior chamber too. And you can see on histology how it gets into the various cells. And so this is a rabbit that has undergone a PTK, a phototherapeutic keratectomy. And again, we've put this antisense oligonucleotide into the cornea, and it heals up. And you can see on the left side a rabbit that got just an oligonucleotide to something completely unrelated. And on the right side, they got it to anti-CTGF. So it was targeting the CTGF, the connective tissue growth factor. And you can see a very interesting change in the amount of scarring. And here again, you can see on the top are all the scrambled oligonucleotides, and at the bottom are the ones that actually target CTGF, and the scarring is significantly reduced from that. So we know that we can reduce scarring by providing this protein. And then we started looking at, so one of the things that I'm interested in is herpes. So I was very interested in the last talk by Dr. Garg, because I diagnose everything with herpes, right? Because it's you have an idea about something and you go for that. And so we were looking at that, and how do we get something to, again, the herpes affects the cornea, but the problem is in the trigeminal ganglion. That's where it's sitting and it's reactivating. And so we used AAV, which is the same vector that Dr. Houseworth used for his LCA and RP studies. It's a very, very tiny virus. The good thing about the virus is it's so tiny that it can get into tissues easier. The problem is it's so tiny that you can't load it with a whole lot of genetic material. HSV and adenovirus are bigger viruses, but then it's harder for them to get in. And then lentivirus has been used clinically in cancer, as you guys all probably already know. The cornea, and the nice thing about AAV is that different varieties of AAV target different tissues. And so here you have AAV2 and 5, which tend to have a propensity for the corneal tissue. And so it actually, the 2 and the 5 get into different cells, but you can see how the endothelium is lit up. You can see the epithelium lights up, and a lot of the keratocytes light up with these vectors. And then what we used is a ribozyme, which is something you can custom make. And so you take the mRNA that you're interested in, and you make this ribozyme to match it, so it complements it. You remember your AGTC and then the opposite pairing up. And so you pair it up, and then the center portion, this little loop here, actually cuts the RNA. Once you cut an RNA, it becomes very unstable, and it breaks down, the cell eats it all up. And so you can use this to target mRNA that helps the virus make capsids and replicate itself. We gave it by an intrastromal injection into the cornea, and then it enters the nerve endings, and what we use is actually serotype 8, which has a propensity for neural tissue. And here you can see the trigeminal ganglion, and then this is the one that has the AAV vector that's gone into it. So AAV8 goes right into the trigeminal ganglion. And so these are rabbits that have HSV that has been latently infected, just like us when we get HSV. So it's sitting in the trigeminal ganglion, and we give them an iontophoresis of epinephrine to make it reactivate. The left side is is a rabbit again, that got one eye that had just the AAV vector without the ribozyme. On the right side, on your right side, is the one that got the ribozyme that kills the HSV. And when we reactivated the HSV, you can see that the left eye does not have HSV lesions, showing that it did actually suppress that, and we've shown that with histology too. There's some investigational drugs that are commercially now trying to be available, where you can inject AAV into the lacrimal gland, the thinking that you would then make it in the tear film, and you can make nerve growth factor for patients who have neurotrophic keratitis, and maybe use some enzymes that you produce yourself that break down histamine for vernal keratitis. So very interesting work that's being done in gene therapy everywhere. Thank you.
Thank you, Dr. Sonal. Something to think about for future. Just, do we have some clinical studies coming up?
So they're working on these enzymes, and we're actually starting on, thank you. I don't have a commercial interest yet because we don't have the company yet, but we are starting the HSV studies, hopefully clinically soon.
Thank you, thank you.
Do you think the post-PRK AIDS needs genetic treatment? Because post-PRK AIDS is almost nil due to mitomycin use.
I'm sorry, tell me that again?
The post-PRK AIDS
Yes.
is almost not there after use of mitomycin.
Yes, and again, you could use mitomycin for haze, but again, it's a big gun, right? It kills the keratocytes, it causes apoptosis, and it causes prevention of healing, and there are long-term side effects. Whereas if you target the CTGF independently, the thinking is that you won't have other off-target effects that could cause weakening of the cornea or prevention of epithelium healing. So it's thought to be a little bit more targeted, and maybe avoid the risk of mitomycin.
After her.
Thank you.
The next speaker is Dr. Prabjot Channa from Rhode Island, and she'll be speaking on positive pressure and PK.
Hi, good morning, everybody. Hi, good morning, everybody. Switching gears from something advanced to something more basic, I'd like to thank the scientific committee for inviting me. Lamellar keratoplasty has made corneal transplantation safer. Endothelial keratoplasty is currently the most common keratoplasty procedure done in the United States. Despite this rapid growth of selective lamellar keratoplasty, PK is still a very essential procedure for full-thickness corneal diseases. In India, penetrating keratoplasty is the most performed transplantation procedure. For the Eye Bank Association of America, the annual number for PK, DSEC, and DMEC were essentially the same for the year 2022. In India, the most common indication for penetrating keratoplasty was corneal ulcer, followed by corneal scars and failed grafts. We all have experienced positive pressure. It is an uncommon but serious complication, and the signs depend on the severity of positive pressure, which include, as we all know, a shallow anterior chamber often resistant to reformation, repeated iris prolapse resulting in lens expulsion. There's a forward bulging of the posterior capsule, often with rupture leading to vitreous loss and the dreaded expulsive hemorrhage. The incident rate is reported to be as low as 3.6% to something as high as 40 to 50%. We are all familiar with the ocular risk factors, which include iris pathology, a shallow anterior chamber, patients who have low scleral rigidity, patients with acute angle closure or chronic glaucoma, or short axial length, and high myopia. Acute hypotony sets the stage for positive vitreous pressure. You have an open anterior segment which leads to aqueous loss and resultant hypotony, which leads to elevated vitreous pressure, creating a pressure gradient between the vitreous cavity and the open anterior chamber, which in turn leads to elevated pressure, causing a loop, leading to prolonged surgery, prolonged hypotony, choroidal effusion, and choroidal hemorrhage. To reduce the risk of positive pressure, we need to minimize the degree and duration of hypotony during the surgery, minimize a sudden drop in intraocular pressure, which you can achieve this preoperatively by IOP reduction using topical and systemic medications, recognize and control risk factors such as hypertension, congestive heart failure, and COPD. Preventing external gope compression is very important. Optimize echinacea. If you're using general anesthesia, it should be deep and or with systemic muscle paralysis using non-depolarizing agents. If you give an intraorbital block, minimize the volume to prevent excessive orbital pressure. Add hyaluronidase to facilitate anesthesia spread. A gentle ocular massage or compression also helps anesthetic diffusion and softens the eye through increased aqueous outflow. Position the patient in a reverse Trendelenburg to reduce orbital and choroidal venous congestion. Make sure the eyelid and the speculum does not press the globe. If squeezing, use an eyelid block. And scleral support using a Floringa ring is really helpful. It's important to identify surgical approaches that can minimize intraoperative complications, thus ensuring donor tissue preservation. Recognize early the signs of positive pressure, and quickly reassess the situation and cause, if any, and simultaneously prepare for rapid wound closure. If the situation gets progressive and vitreous presents, digital ocular tamponade may help useful. Price described the graft over host technique in 1998, wherein the graft is sutured across a trifine host cornea, which maintains a formed anterior chamber and avoids the intraoperative complications. This is an effective procedure. I have used it in the presence of posterior pressure. In their series, there was no primary or secondary graft failure reported in the 33 eyes that underwent this technique. I could not get a video, neither from Dr. Price or neither did I have one. So I took a YouTube clip. This is in a pediatric eye showing a recipient cornea that is trephined and sutured. A copious amount of viscoelastic is then placed on the recipient bed. The donor is laid over this and sutured in 3 quadrants. And just before you close the last quadrant, the recipient cornea is removed from underneath and the eye is closed, maintaining an anterior chamber throughout. A modification of this was described by De Caris, wherein the donor graft is anchored over a partially trephine recipient cornea, which is placed with cardinal sutures, and donor is sutured using continuous sutures as each recipient quadrant is incised. The anterior chamber is thus kept stable. 8 of the 220 eyes of standard penetrating keratoplasty were operated by this technique, and none were reported to have primary graft failure. A modification of this was described by Chen et al. To secure the anterior chamber in penetrating keratoplasty. This was inspired by DALK, which stabilizes the penetrating keratoplasty procedure as the anterior chamber is maintained throughout and reduces the disadvantages associated with an open sky technique. Factora, which also described a similar approach, the host cornea is incised incompletely and remains attached at the 6 o'clock and 12 o'clock positions. And the host cornea is then slit from beneath the donor cornea after the initial cardinal sutures are placed. Managing posterior pressure during pseudophakic keratoplasty can be challenging. McCartney and all described a limbal skewer technique in pseudophakic eyes, wherein a 2.5 centimeter 27 gauge disposable needle is passed limbus to limbus. The skewer stabilizes the IOL and maintains the anterior chamber depth while suturing the donor tissue. You do need an assistance to tamponade and hold the IOL back. It's a little difficult technique. Simcoe first described a triangular retaining suture positioned over the pupil and IOL to prevent IOL touch to the corneal endothelium in penetrating keratoplasty. And Chung and all described a modification of this technique wherein quadrangular mattress sutures can be placed before or after trephination in the presence of posterior pressure. The mattress sutures are placed limbus to limbus. A second mattress suture is placed in the opposite meridian for added support, thus forming a basket. This normalizes the lens-iris complex, and in a retrospective review of 15 PK eyes, successful surgery was achieved in all cases with no primary graft failure. Co-vitrectomy and vitreous aspiration preceding triple procedures have been described to lower positive pressure. In both the above papers, they had control groups and found better success rate of IOL implantation in high-risk triple procedures in patients that underwent a co-vitrectomy than in those that did not. In conclusion, posterior pressure can present a stressful and challenging situation. Be expeditious in your technique. Modify your technique to minimize intraoperative complications. Use a generous amount of OVD to ensure donor tissue is preserved. And theoretically, the risk of primary graft failure using these techniques is outweighed by the risk of trauma to ocular tissues and vision loss in the presence of posterior pressure. Thank you.
Thank you. So identifying risk factors and then taking care of the positive pressure is very important. So based on the risk factors, probably one can take a call and decide which technique one has to use.
I think the graft actually all of them basically work on maintaining the chamber. So if you make an incision and you notice iris prolapsing, I would put sutures and then put a copious amount of viscoelastic and just try to maintain the chamber. And I think it works pretty well rather than having everything on your face.
Thank you so much. The next speaker is Dr. Vishal Jhanji, and he'll be talking on advances in dry eye imaging.
Thank you. I'm sorry I'm late. The city's food and traffic both slowed me down. First more than the second one. So I don't have any financial disclosures relevant to this topic. This is going to be probably a straightforward talk, but again, something that we keep on forgetting and we need to remind ourselves time and again. Principles of diagnostics in dry eye imaging is we basically measure the tear film secretion. We look at how stable the tear film is. We look at the integrity of the tear film, and of course there are always lab tests for those of us who work in a slightly sort of more academic center. When it comes to tear film quantification, the most commonly used testing is using tear test strips. They're gently brought into contact with the ocular surface for a few seconds, and basically you can quantify the tear volume. Sherman's test is the most commonly used test. We still use it quite a lot actually in our dry eye Sjogren's clinic, but there are other tests available as well. The more commonly used test in clinical practice is actually the tear film breakup test. we basically look at how quickly the tear film breaks when a patient blinks and you ask them not to blink again. In a more advanced version, you basically do a non-invasive pre-breakup time, and I'll discuss that separately using all these devices that are listed there. You can look at the tear film integrity basically in a similar way. You look at the conjunctival and corneal staining, you note any unstable tear film. Using fluorescent dye, you can use rose bengal and also lissamine green, depending on what is available in your clinic. This is the NEI grading corneal, for corneal staining, one of the most commonly used tests in a clinic. Some of us are rather busy in the clinic when you look at dry eye patients, but if you have a proper dry eye clinic, I can assure you this really helps you specifically when you're looking at patients at follow-up visits. You can also use the DEQ questionnaire. It's very straightforward compared to the more commonly and more popular ocular surface disease index, which is basically a positive symptom score on a list of questions that are listed on a form. Presence of any of these three specific signs actually indicates dry eye disease, reduced tear breakup time, can be invasive or non-invasive, any ocular surface staining, whether that's on cornea or conjunctiva in either of the eye, and elevated or large intraocular disparity in osmolarity. This is a picture that shows basically how you can use non-invasive tear film time on one of the devices called keratograph. You can see it actually gives you a visual map. You can actually measure the tear film meniscus height using one of these devices. They're very commonly available now. We do utilize the newer versions of anterior segment OCTs, basically, which is a low coherence interferometry device. You can look at the upper and lower tear film meniscus height. You can actually measure the volume in different areas, especially at the junction of bulbar conjunctiva and the lower eyelid. You basically know the average value of tear film thickness is about 5 microns. In addition to that, of course, you will get an idea about the corneal pachymetry and epithelial thickness mapping, which is gaining more advantage, especially in drug toxicity related dry eye nowadays. And of course, you can use the same anterior segment OCT to image the meibomian glands. Again, a picture showing how you can actually look at the lower tear meniscus and look at the height and the radii in different patients' eyes. The TSAS, or tear film stability analysis, we still have this old-fashioned machine, which is actually very useful and quick, gives you 10 topographic images at 1 second intervals. Again, a very easy device to use when you look at the images. Of course, the all green image is from a normal patient, and you can see the TSAS map from a patient with dry eyes. You can use aberrometry. Basically, it's a non-invasive assessment of visual disturbances that can detect dry eye disease, and you can again monitor the efficacy of treatment. So basically, the concept is the same. You're looking at the surface irregularity index. So with the increasing availability of devices to treat meibomian gland dysfunction, lipid layer analysis using interferometry has become more common. You're basically looking at color fringes that arise from interference between the light reflected from the lipid layer and the interference between the lipid and the aqueous layer of the tear film. There is some correlation between dry eye symptoms and a thin lipid layer, which is less than 60 nanomicrons, and lower lipid layer thickness also portends a higher probability of MGD in a patient. You can do a video recording using the LipiView device, which basically tells you if a patient is an infrequent blinker. And it's not uncommon for patients to look at you in a weird way when you ask them, are you blinking frequently? As I mentioned, MG assessment has become more and more popular and commonly used in the clinics. There are different ways to grade meibomian gland dysfunction. You can actually look at the gland expression. Here's the grading, which is very commonly used. It can be anywhere from a clear meibum to thick toothpaste-like meibum from the glands. You can use meibography, which is basically in vivo imaging of meibomian glands. The most simple way actually is to use one of your existing anterior segment OCT devices. You don't need to use anything fancier than that. This is basically showing the normal and abnormal architecture of meibomian glands in a patient with dry eyes. And of course, if you use a different version that employs something to assess that using AI software, you can actually grade or quantify MGD as well. You can also use as the bulbar redness evaluation software on the keratograph. I don't find it to be very useful really. It depends sometimes if a patient has had a long night, and of course there are different things available, software available on machines that can basically look at this. I'll just skip through this. You can use confocal microscopy. If you have access to that, it's really useful, especially in patients who have rheumatological dry eye. This is from a normal patient, a patient with dry eye, and a patient from Sjogren's syndrome. You can see the size of the acinar units in patients with Sjogren's syndrome. Impression cytology is basically used mainly for research purpose. We use impression cytology a lot for our dry eye patients where we are planning to study the ocular microbiome in these patients. You can use the newly available or relatively newly available impression cytology devices where you really have sort of this plunger which goes into the conjunctiva and you can get a good sample and subject that. So to conclude that there's no ideal automated test. You really have to rely on clinical exam, proper history taking. You can use any of the available sort of devices to quantify the dry eye disease in your patients. Thank you for your attention.
Excellent talk, Dr. Jhanji, as usual. So, just I wanted to ask you one thing, that you have shown that in your articles that some patients with inflammatory dry eye, in confocal microscopy, sometimes or even in that specular microscopy, they are having less endothelial cell count. What's the reason for that?
Endothelial cell count?
Yes.
Yeah, I don't think they're supposed to have lower endothelial cell count. It might be, I don't know what you're going to use.
People are having this inflammatory dry eye for a long time. Now that impacts this endothelial morphology of all those things.
I'm not aware of inflammatory dry eye affecting the endothelium per se. I mean, there's something else probably going on along with inflammation, which is causing intraocular inflammation that can affect the endothelium. I don't know what the panel thinks.
No, he's right. So there is some evidence that patients with chronic, so the thinking is that it's a chronic neuroinflammation that's causing the dry eye on the ocular surface. So when you've got neuroinflammation generally, even in the stroma itself, there's some effect on the corneal endothelium. So Residena has a paper exactly showing that itself, where patients have slightly low endothelial cell count when you compare it to normal. But these are in chronic patients, and often there's a neuroinflammatory response to the dry eye, the underlying pathogenesis of the dry eye disease. So it depends then what's the long-standing pathogenesis. But
yeah. And a good example would be, again, neurotrophic keratopathy. Those patients would definitely have some impact on the endothelium, but something else is going on as well. Thank you.
Okay, so our next speaker is Dr. Audrey Rusrob, and she'll be talking on managing complications in DMEC or DSEC. Over to you, ma'am.
Thank you so much. It's a pleasure to be here. It's exciting to see so many friends again. And if I could have my slides, please, that would be helpful. Thank you. I'm going to be discussing managing complications in DMEC and DSEC. My financial disclosures, none are relevant. I'm going to concentrate on these three different scenarios: DMEC or DSEC after PK, DMEC insertion issues, and intraoperative hemorrhage. In general, I tend to do DMEC when there's a good view. It's my go-to for previous PKs, phakic patients or failed DSEC with minimal comorbidities, and DSEC for those more complex cases. When you are doing an EK, whether that's DMEC or DSEC following PK, you want to be sure about your graft sizing. I usually undersize about 1 millimeter, and so if you had a previous PK that was 8 millimeters, consider a 7 millimeter DMEC or DSEC. Also, you want to be aware of PAS. If you do have synechia, you may need to do a DSEC with a custom shape, like I learned from Dr. Praveen Vadavali, where you cut off an edge, sort of like a letter D. Keep in mind, larger grafts can be more difficult to unfold. For desmetorrhexis, when you have DMEC after a PK, you do have to strip endothelium. You do not with DSEC, although I tend to do that for both. And you want to be careful because you have to avoid the graft-host interface. When you are doing a DSEC following a PK in the scenario where you have aphakia or aniridia, I like to use a stay suture. And this is suturing the donor lenticle to the previous PK graft. You could see here that in this scenario, I was really happy that I did that, because that is the only thing keeping this donor lenticle from falling to the back of the eye and the retina. You could see that there on the OCT below. I was able to go ahead and rebubble this graft successfully. It's hard to do air bubble management in these cases. This is another trick you can use. This is what I call a safety suture. Whether you're doing a suture pull-through technique in the face of either aniridia or very little iris. This is someone I did a scleral fixated lens and a DSEC. They had a failed graft. They also had a tube. And so it's an older video, but you could see here what I'm about to do is place that suture there so that just in case the DSEC lenticle is going somewhere I don't want it to, and here's a push-in technique. You can also do a pull-through technique. I have that as a safety suture. This is the same patient post-operatively, about a month post-op, and that's the upper photo. There is an increased risk of graft failure with DMEC or DSEC with a history of glaucoma drainage devices, and so to keep that in mind, I know that Dr. Aldalvi is going to be speaking about that. When you have a previous PK, you need to be careful with your air bubble management because there is potential for rupture of the PK wound. You want to inject slowly. I like to use a 1 cc syringe. Here is a scenario where I did not, in fact, follow my own instructions. I aggressively injected, and that is the rupture of the PK wound. You think you're almost done, and now you have to sew up a good portion of the PK. Another tip when you're doing DMEC insertion, do not insert a DMEC graft into an overpressurized eye. If there is resistance on insertion, do not force it. Again, I did not heed my own advice right here, and I'm pushing and I feel resistance, and I still feel resistance. And what happens? There we go. Yeah, that's kind of a bad day when that happens, so you want to avoid that. I promise I also do successful DMECs as well. I wonder why they always ask me to talk about complications. Perhaps it's a hint. So again, what happens if you have pressure on DMEC insertion, but you did not see the graft coming outside of the eye? Well, you've got to look for it. And this is actually what happened. I didn't know where the DMEC graft was, and so I'm using a little Kugelin hook, a push-pull, and I'm looking through the pupil, and it wasn't there. And so here, this is actually, it was a YouTube song that went, you know, I still haven't found what I'm looking for. This is a reenactment of actually what we did. We took the fluid out of the drape pocket and put it into sterile bowls, and that's how we finally eventually found the DMEC graft. We still didn't see it, but then we added trypan blue to the little bowls and then figured out where it was. What happens in this case, some of you have seen this video. I still get nightmares from it. In fact, it makes you feel a little sick. You might be sorry you had a large breakfast. I'm about to insert the DMEC graft, and oh my goodness, what happens here? Yeah, it's like a scary movie. I'm pretty sure I have hit the aorta at this point in time, and I have to irrigate out. So the first thing you want to do is save the graft, right? You want to make sure that the graft is safe, so you're saving the graft, irrigate out, figure out where that's coming from. It can either be coming from the PI, it could be coming from the wound. In my case, it was coming from the wound, and I finally figure out where this is coming from. And yeah, the eye fills with blood once again. You think you're home free and you're not. Eventually, I did locate the site of the bleed and then got it under control with some tamponade, and I was able to successfully, in fact, insert the graft and unfold it. Management of intraoperative hemorrhage. Number one, do not panic. Take your own pulse. Establish the source. maintain the safety of the graft, and then tamponade with whatever you have, air, viscoelastic, epinephrine, adrenaline, BSS, whatever you think will work at the time. In summary, with EK after PK, you want to size the graft smaller than the PK in either a DMEC or a DSEC. Remember about safety and stay sutures both as good tricks. Inject air slowly so you don't do what I did. Do not insert into an overpressurized eye with DMEC insertion. Obviously avoid the pupil. Thank you so much. It's a pleasure to be here.
Any questions?
Would you let me ask a quick question then? What is your thoughts on, to avoid bleeding from the PI, a lot of people say, especially in the Fuchs cases, maybe doing PI preoperatively with the laser so you avoid the issues when you're doing intraoperative. And the second thing I was going to ask was, there's some sort of discussion about maybe trying to give some fibrinolytic to basically get rid of fibrin, because even though you get rid of blood, of course you're going to get more aqueous fibrin release as well, which obviously is very difficult to get rid of. And with an endo-out technique, you've always got the chance of it sticking like glue to the fibrin area. Do you know what I mean?
Yeah, actually, both are good points. One thing I've taken to doing is I've taken to stopping blood thinners. That patient was on Eliquis, and so I never used to stop blood thinners, and now I actually do for DMEC and DSEC a couple days ahead of time. Certainly, fibrinolytic is a good idea if you have access to that. I think that that's an excellent concept as well. Both are very good ideas.
Will you do DMEC in aphakic eye?
Sorry?
Will you do DMEC in aphakic eyes?
In aphakic eyes? I don't, because I like life to be easier, and so if it's in an aphakic, if it's an aphakic eye with an iris, which is not usually the case, then yes. But if it's an aphakic eye without an iris or a very little iris, then why make life more complicated is my philosophy. I have enough complications as well, so as you can see.
What about the rebubbling rates in post-PK eyes for DSEC and DMEC?
Sorry, what's?
Rebubbling.
Oh, rebubbling rate, sorry. The rebubbling rate is actually maybe a little bit higher in DMEC after PK, but not terribly so, as long as there's no other confounding factors such as glaucoma or a glaucoma drainage device. I used to do DMEC on everything, right? And now with glaucoma, I've tended to be more picky. If there's a glaucoma drainage device, like a tube, for example, then I tend to just do a DSEC because I know it's going to fail earlier anyway, usually.
Yeah.
Thank you.
Thank you. I think in India, most surgeons prepare their tissue themselves. So we get enough time to tamponade the anterior chamber. Once we do a PI, we inject the air bubble, and that maintains the pressure for that particular time. In the meantime, you shift to prepare your DMEC or a DSEC tissue, and that gives enough time for oozing to stop, and you have a nice controlled uninflamed and blood cells in the anterior chamber.
Yeah, I do the PI at the time of surgery. I know people who do it ahead of time. Most of the time, I do not have an issue with it. Of course, there's always that potential, but
especially
most of the
if you
time
use a vitrector for doing iridotomy, that's quite safe. Thank you.
Yeah, thank you. The next speaker is Dr. Anthony Aldave. He'll be talking on DMEC in glaucomatous eyes and deep anterior chamber.
Thank you very much for the invitation to speak, and given the time that was given, I decided to focus on DMEC in eyes with deep anterior chambers. Great to see standing room only here. How many people in this room do DMEC surgery? Okay, good. So this will be relevant for you guys. For those who don't start with deep anterior chambers. Start with simpler eyes. None of my disclosures are relevant to this presentation. So we're going to talk about a couple of techniques for endo-in DMEC and then endo-out. So here's a patient of mine, prior trab, pressure of 3, post-op, deep anterior chamber, post-vitrectomy, and as you see, this graph's a little bit big for this eye. So I usually use a tapping technique to unfold, but I'm not getting anywhere in this case because I just cannot shallow this chamber. It does not respond. All of us that do a lot of DMAC know how the graft should respond, and when it's not responding, there's a reason. Vitreous, deep anterior chamber, fibrin, something. But here I'm just struggling to try to get one portion of this graft unfold to my left, which is my preferred technique, and then unfold to my right. Even when I'm just trying to move the graft over, it's not moving. So in a case like this, you have to avoid just sort of repetitive tapping that's non-purposeful. That's why I tell the fellows, every movement should have a purpose. Stopping, shallowing the chamber again. Here you see drawing some fluid out. In this case, it's just not unfolding. So what I recommend in these eyes, take advantage of the depth of the chamber and use this direct manipulation technique with your cannulas. Here we're touching the stromal side of Decimase to unfold that leaf. Much easier than trying to tap it out. In a chamber that's deep, it will not shallow on you during this maneuver. Once you get that portion unfolded, then it's like a routine case. I like this compress and release technique. It's a slow downward movement and then a rapid upward movement to create a vacuum that pulls this graft open. You'll see me use it again here. So it's a quicker upward stroke, creates a vacuum and pulls that graft open. Once you have it open, then you can get your air bubble beneath it. In a deep anterior chamber, you may never get the graft to completely unfold. You may still have one edge that's still folded. You'll see in the next video, don't worry about that. Get the air bubble beneath it and you can then tap out that edge. Here's another endo out case. This case, no trab, but deep anterior chamber. Post-vitrectomy, high myope. And again, I am struggling to get this out of a tubular configuration and try to make it flat. Doing everything I can, I'm tapping on it. I've removed as much aqueous as I can. I'm going to go in, and in this case, I'm not just burping fluid, I'm actually aspirating fluid out of the anterior chamber. When you do that, then you can see that whole cornea sinks. Now we have a concave cornea. You'll get that sort of annular light reflex off the concave cornea. If you're not getting anywhere, stop. 1 cc syringe with 0.1 cc of air. Go beneath the iris. Go out as far as you can towards the iris root and inject a very small air bubble. If you're peripheral enough, it won't go through the pupil. Just bring the iris plane up towards you. In this case, I'm doing it along where the graft is positioned. Now I've got the iris is up. I'm actually able to get this cornea in more of a flatter configuration that's going to allow me to begin to unfold this graft. A finger on the globe can also be very helpful to bring that iris plane up on these eyes that have very deep anterior chambers. And when you release that finger, the cornea will become concave again. It will sort of lock in a graft. You've been able to unfold it. One other technique I like to use, I call it the vampire technique or aspiration technique, which again is coming in with a 30 gauge cannula. This time you're touching the endothelial side, but a very small area. You're going to aspirate and pull that graft over. You cannot do this in a normal eye, but you can do it in these very deep chambers. So another technique to really help you try to get one side unfolded, then allow you to unfold the other using whatever technique you like. You can see here doing it again. It's actually quite easy as long as the edge of the graft is curled up. If it's flat, you can't do this. But if it's curled up, as it usually is in a deep anterior chamber, it's a very nice technique to pull the graft over and then allow you to begin to unfold it. Now I've got this side unfolded. I'm going to do the same technique you saw in the prior video with that cannula, the direct manipulation technique. Going to push this other side unfold. So in this case, I've unfolded the graft without the normal tapping technique. One side I aspirated, the other side I pushed with the cannula, and lo and behold, got this graft unfolded. Now you see where the S is, we still have an edge fold. There's no way of getting this graft completely unfolded. But as long as you get air beneath it to pick it up, as long as you don't have air underneath the folded edge, you can then tap it out. So you just tap at the limbus, and this edge should unfold. If it's not unfolding for you, it's probably because you have air beneath what's folded. You need to reduce the size of your air bubble. Once that's unfolded, then we're in good shape. We're going to fill the anterior chamber. And these are challenging eyes. If you know you have a deep anterior chamber, one of the things you can do to make your life easier is make sure you request older tissue from the eye bank. U.S. eye banks are now recovering from patients up to age 80. And so you ask for a tissue of somebody in their 70s when you know you have a deep anterior chamber, so you're not struggling with both a tight scroll and a deep anterior chamber, which is a deadly combination. So in cases of endothelial mount technique, techniques to shallow the anterior chamber, releasing fluid, we're all familiar with that, placing air beneath the iris. People say, well, don't you have to get that air out? Yes, you would ideally, when you're going to be taking the air out at the end of the case, push on the iris and try to burp it through. But a very small amount of air behind the iris is usually not an issue. Digital pressure on the globe during the unfolding maneuver and then releasing it to prevent scrolling of the graft once it's unfolded. Techniques to unfold and center the DMAC graft. That compress and release, the slow downward, rapid upward is one of my preferred techniques for unfolding. Direct manipulation of the graft using 1 or 2 cannulas. Some people will put in 2 cannulas and then move them apart to unfold the graft. Aspiration technique, or the vampire technique, and I didn't show you this injection of air bubble above or below the graft. If you're really struggling to unfold it, you can just put an air bubble above it, flatten it like a pancake on the iris, and then go below it and bring it up with an air bubble. Now, endo-in is another technique. In this case, the graft's going to be folded either by the surgeon endo-in or by the eye bank. And this is really helpful for these deep anterior chambers. This takes the depth of the anterior chamber out of the equation. So this is an animated video from CorneaGen. I have no financial interest, but I do consult for CorneaGen. What this technique uses are these irrigating forceps. So it's your forceps very similar to what you would use for DSAC surgery, microforceps, but with this irrigating sleeve that's coaxial. So while you're holding the graft inside the eye, the coaxial fluid flow helps to unfold the graft again because the graft's folded endo-in. So this is a demonstration what those look like. This looks like, of course, the EndoGlide, very similar to what you would use for DSAC surgery, but adapted for DMAC surgery. So here we see the forceps coming across the anterior chamber, reaching across to grab that DMAC graft, pulling it into the anterior chamber. Again, the irrigation is coming through the forceps. You could use an AC maintainer as well if you wanted, but in this case, since the flow is coming from those forceps, that flow helps to unfold that graft. Now, I'll show you this in action. This video is courtesy of Divya, who just gave this to me, who many of you know. So here's a case of hers, which she's using these forceps. This graft, again, is endo-in. So she's just holding on to it, and by either the assistant pushing on the plunger, or you can use surgeon-controlled foot pedal to control the irrigation, the graft unfolds spontaneously. Once it's unfolded, then you just sort of tap it to move it in position. So in this case, it doesn't matter how deep the chamber is. It's unfolding because of the fluid flow along the forceps. You don't need the iris plane to unfold the graft. So this technique is really helpful for these deep anterior chambers. So using this endo-in pull-through technique, the DMAC graft is folded by the surgeon or by the eye bank. Infusion, again, either controlled by an assistant or the surgeon. It's really helpful technique to transition for your trainees from DSAC to DMAC. Also avoids the need to shallow the anterior chamber to unfold the graft, and makes it possible to do DMAC in eyes with ACIOLs or sclerofixated PCIOLs. Thank you very much for your attention.
Thank you, Dr. Aldave, for a nice, giving us tips for a deep chamber. Opening the DMAC roll is so difficult most of the time. In the last video, your hold is, a single point hold in the DMAC roll. Will that flip sometimes inside the anterior chamber with the fluid on?
Shouldn't flip. I mean, if the fluid infusion is controlled, the graft should not flip upside down, for example. It may crumple up, but as long as you still have a hold on it, you should prevent it from being able to flip over. Just like with a DSAC graft, it should not flip over if you have a proper control of the graft, a hold of the graft.
Yeah, but terrific technique. It makes things life simpler if the graft opens up inside like that.
It doesn't work like that all the time, but when it does, it's awfully nice.
Yes. I think, we did cover the entire range of things which can be covered in our cornea session, right from the dry eye to infectious keratitis to keratoplasty and endothelial keratoplasty, difficult situations. I think we can take 5 more minutes here, though we are on time. Any question from the house? I think the speakers are here. They would definitely be happy to answer those questions. All of you are cornea surgeons, and you are from the Cornea Society here. Please, any questions? I see Dr. Kuris standing there, He always has a question. Oh, no? That's not the question.
One question I just asked is whether CorneaGen is the only company that offers this endo-in. Actually, there's other eye banks in the U.S. that do export internationally, like Lions in Tampa. They have a cannula that looks, has a flat portion where the graft resides. It's folded endo-in. In that case, you don't need forceps. You just push it in like you normally do, but the way the graft is folded, it tends to unfold spontaneously in the anterior chamber. It would also be useful for these deep anterior chambers. So there's several eye banks in the U.S. that provide preloaded endo-in DMAC tissue.
Yeah, that's great. I think we would like to conclude. Thank you all the speakers for making this session so wonderful. I'd like to thank Jyot and Dr. Sujata for coordinating this, and to Hind and Dr. Rathi for making such a nice.
Now we will have a group photo.
Group photographs, and just wait for a minute.
All the speakers, please come.